Hi, I'm Dr. Suresh Ramalingam, Professor of Hematology and Medical Oncology at Emory University Spinship Cancer Institute. So first of all, let's review the definition of limited stage small cell lung cancer. This is referred to a group of patients where the disease is localized or locally advanced and can be fit in one radiation port for patients to receive radiation. And this definition comes from studies done 20, 30 years ago. So for patients with disease that's limited to one lung and mediastinal nodes, no contralateral involvement, we use chemoradiation as the standard approach. Platinum-based chemotherapy is used. Cisplatin etoposide is preferred. If a patient is not a candidate for cisplatin, then carboplatin etoposide is a reasonable approach. And we usually use 4 cycles of chemotherapy in these patients. We have to give radiation concomitantly, and in most instances, radiation is started at the same time as cycle 1. But we know that sometimes patients present with small cell lung cancer are initiated on chemotherapy right away before sufficient time is available to complete staging workup and refer them to radiation oncologist. So in some instances, radiotherapy is started with cycle 2 of chemotherapy, and which is also appropriate. There's been a long debate on what is the optimal dose of radiation, what's the optimal schedule of radiation. Using radiation twice a day, 45 gray of radiation twice a day has long been considered the gold standard in this setting. But coming twice a day for radiation does have logistical constraints. So many radiation oncologists would give 60 gray on a once daily fractionation. So this is something that the institutional practice would define whether a patient gets BID radiation or once a day radiation concomitantly. The next question is, after patients complete concomitant chemoradiation, prophylactic cranial irradiation is considered. Any patient who has a good response to chemoradiotherapy approach should receive prophylactic cranial irradiation in the setting of limited stage disease. Why? Because we know that brain failure is a common problem in limited stage small cell lung cancer. And when prophylactic cranial irradiation is used, there is approximately a 5% improvement in overall survival at the 5-year time point. So the current standard is chemo with concurrent radiation followed by PCI. Obviously, the bigger question is, what does the future hold for limited stage small cell lung cancer? Where does immunotherapy fits in? We know that addition of chemo to immune checkpoint inhibition, or other way around, immunotherapy to chemotherapy in extensive stage small cell lung cancer leads to improved overall survival. So now there are ongoing trials that are looking at the addition of immune checkpoint inhibition with chemoradiation in limited stage small cell lung cancer. This also makes sense considering the PACIFIC trial in locally advanced non-small cell lung cancer showed that adding durvalumab after chemoradiation resulted in improved overall survival. So there's an ongoing NRG oncology trial that will look at the role of atezolizumab in the concurrent chemoradiation therapy setting for limited stage small cell lung cancer. Other immune checkpoint inhibitors like durvalumab, pembrolizumab are also being studied in the limited stage setting for patients with small cell lung cancer. So when we think about small cell lung cancer, obviously the most important thing to remember is while we have come a long way with improving treatment approaches, there's still a lot we can do for patients and we need to do for our patients. The 5-year survival rate with chemoradiation alone remains in the low 25 to 30% range. So adding immunotherapy to me is a potential new exciting way to improve outcomes, and therefore looking for clinical trials to enroll these patients in order to bring better treatment approaches to the setting is critically important. When it comes to PCI, or prophylactic cranial irradiation, one of the practical challenges is toxicity, because patients can develop radiotherapy-related events. Now there is a new approach called hippocampal sparing radiation that's being studied. That approach could result in better tolerability and lesser long-term effects on cognition and memory with prophylactic cranial irradiation. So there are ongoing trials looking at hippocampus sparing radiation in the setting as well that could help us improve the treatment approaches, the tolerance of treatment approaches, and also seek to improve overall outcomes.